Hi everyone, Ensign Flood here. So today we're going to talk about stroke and let's just dive right in. So basically I'm showing some non-contrast CTs of the brain because this is incredibly important for diagnosing stroke. So here in the middle we have the normal CT. On the right we have an ischemic stroke, which you can kind of see these darkened lesions right to the periphery. And in the case of hemorrhagic stroke here on the left, you see these white foci where blood is collecting. So besides ischemic and hemorrhagic, there's different subcategories of each, and this depends a little bit on the patient's history. So if a patient has a hemorrhagic stroke and they had a mechanism of injury, it's most likely going to be traumatic. If a patient has hypertension and a reason to believe that vessels are weakened, such as an aneurysm, they might have a spontaneous subarachnoid hemorrhage, in which case they'd be reporting this sudden and severe headache. If the patient had the history of hypertension, but maybe the signs and symptoms are getting progressively worse and now including signs of an increased intracranial pressure like nausea, vomiting, or papilledema, then you're wanting to think about intracerebral hemorrhage. Now, on the ischemic end, the most common is thrombotic, so basically plaques inside of the vessels. So you want to be thinking about those patients who have the metabolic syndrome. Perhaps they've experienced a couple of TIAs, so that's like a angina for the brain, and they might have periods of slight improvement. Conversely, you could be thinking about an embolic stroke. So this sort of history would be more in line with patients who have either AFib or endocarditis, and an embolus gets thrown up to the brain, and so the worst of their symptoms is immediate, and then as the embolus basically gets kind of broken apart a little bit, they get progressively better, but maybe never back to baseline. So really important, don't forget, if you have a suspicion of a stroke, do non-contrast CT first because the treatment will vary between hemorrhagic and ischemic. So hemorrhagic, I mentioned traumatic. Is the patient an older patient? Maybe they had a fall and they tore the bridging veins along the side of their head. So basically this would result in a subdural hematoma. This onset is typically more insidious, and you can see right here basically that convex type of marking. In terms of epidural, what you'd be expecting is a severe injury. Sometimes a vignette might describe a young boy being struck in the side of the head with a baseball, so hitting the temple where the middle meningeal artery is. These patients typically have a lucid interval, which is precisely why they're so dangerous, right? The patient will lose consciousness, wake up, say, hey, I'm doing fine, and then go downhill from there. So this is what's seen as a biconvex finding on a CT. Now, I mentioned the subarachnoid hemorrhage. So basically, these are going to be patients who maybe have histories of aneurysm, Ehlers-Danlos, or adult polycystic kidney disease. So they have those weakened vessels in the brain. And essentially, there's a rupture, the blood goes everywhere, and this person has a sudden and severe headache because of that increase in pressure. Now, other times, you're going to hear about patients who have progressive worsening of their signs and symptoms, and then they have things like nausea, vomiting, papilledema, or other signs of high intracranial pressure. So that's going to be your intracerebral hemorrhage, which we have right here. And this is obviously a really bad one because we see that midline shift. So those are your hemorrhagic. They're surgical emergencies. If it's something like a traumatic injury where it's basically the dural areas that are injured, you want to do a surgical evacuation of the blood, so like a shunt. If it is one of the latter two, well, that's really bad, but you want to coil the vessels that are bleeding. Now, if it's ischemic, we have a totally different approach. So I mentioned thrombotic and embolic, right? So embolism, if they have endocarditis, the mainstay is actually giving them antibiotics because those vegetations are formed by bacteria, so antibiotics should help that. If it's an embolism from AFib, then recall your CHADS 2 VASC. So basically this means stroke gets 2 points. If they're above 2 points, at or above 2 points, they're going to be candidates for warfarin and aspirin to clear those clots unless they have other bleeds, in which case IVC. Now, IVC filter. In terms of thrombotic, so this is the most common. So you're likely going to see a vignette involving TPA. So TPA is tissue plasminogen activator. So plasminogen clears clots immediately, but is really most successful if you give it within 3 hours of the onset. Otherwise, if it's past 3 hours, give them a high-dose aspirin. So you can see why it's really important to do the non-contrast CT first, because if you gave TPA to a person with a hemorrhage, that's going to be really bad. So thrombotic strokes are actually symptom based on areas of perfusion. And what do I mean by that? Well, I mean there are a few major vessels to the brain that commonly get tested in terms of their associated symptomology, and that's based on regions of the brain. So I've drawn out the lateral lobe, or the outside of the brain, and the medial portion, or the inside of the brain. And so if we look at the three major arteries that are involved in stroke, so anterior cerebral artery is going to be in the front of the brain, and then it's going to dive into the brain, covering the majority of the medial or inner brain. Then we have the middle cerebral artery. So this is really more superficial. As you can kind of see, there's not a whole lot of involvement in the medial brain. And then we have the posterior cerebral artery. So this is the back of the brain. So you can see it's in the occipital cortex. So strokes involving the PCA are really straightforward because basically it's going to be visual. These patients are going to complain about what we call homogeneous hemianopsia. So basically what happens is they can only see half of their visual field. So it might be the left visual field in both the left and the right eye, or the right visual field in both the left and the right eye. Now, the ACA and MCA gets a little bit more complicated, but I think we can get through this. The major thing to know is that if you're looking at regions of perfusion and regions of the brain themselves, different areas of the brain correspond with different areas in the body. So you guys might remember basically the homunculus. So that's essentially where we go from foot on the inside of the brain all the way to lips and mouth, etc. on the outside of the brain. So this coincides with the fact that the inside of the brain is perfused by the ACA, the outside of the brain is perfused by the MCA. So let's break this down. So, like I said, we go from toes to essentially the hips inside of the brain. So if you have a stroke in the ACA, what you're going to be seeing are people with more of lower extremity issues. So I put toes for gait apraxia, so basically they don't really have a whole lot of coordination in their lower extremity. I put bladder because these are the patients who get urinary incontinence. They might have involvement with the contralateral legs or hips. Now, if we look at the MCA, we're moving up the body, right? So these are the patients, again, contralateral involvement of the trunk, the arms, perhaps the face. They get this thing called conjugate gaze. So basically the eye looks to the side of the lesion, and they get aphasia. So I put tongue here to remember that. And the thing to remember is that whether this is the sensory cortex or the motor cortex, all of these different signals have to be basically consolidated and processed downstream, so further inside of the brain. And in the case of the motor cortex, we have basically all of these signals converging together and going to what's called the internal capsule, right? So the internal capsule is the site of these lacunar strokes. So basically a lot of the time these are tiny vessels that are hyalinized through diabetes, or just get little thrombotic clots in them. And so these can be completely silent, or they are purely motor or sensory. And the thing about these guys is they're so small you can't visualize them on CT. So in summary, if you're thinking stroke, always do a non-contrast CT first. If it's hemorrhagic, then basically these people will have to be surgically evacuated if they're having something like a subdural or an epidural hemorrhage. Otherwise, coil the affected artery. If it's ischemia, treat them with TPA if it's under 3 hours. Otherwise, aspirin. Thrombotic strokes in particular are based on the vessel involved. So the ACA we talked about starts in the front, goes inside. So these are the lower extremities on the contralateral side with gait abnormalities and urinary incontinence. MCA is on the outside, so facial upper body for the contralateral side with conjugate gaze. PCA, straightforward. It's homogeneous hemianopsia, and then lacunar is silent, not seen on CT, and purely sensory or motor. All right, great job, guys.